Great. So my name is Francis Liu. I'm the Luke and Grace Kim Endowed Professor in Cultural Psychiatry at UC Davis, Emeritus. And I have been lecturing for the past 3 years on the DSM-5 and now the DSM-5 text revision, um, outline for cultural formulation and cultural formulation interview, which are two tools that you can use in your day-to-day clinical work to help understand what the cultural issues are and how that might be helpful in your day-to-day work of differential diagnosis and treatment planning. And so I will share my screen. Okay, can you see that in the full view?
Yes.
Okay. Um, so I have no disclosures, and my email address is listed here. Please take that down, and if you have any follow-up questions that don't get answered in their time together, feel free to email me. If you also want a PDF of the slides and also backup material on this topic, I do have a PDF that I can send you that has all of my slides and backup material. So just email me at francisleumd@gmail. So we'll start with what is cultural competence and why is it important, looking at quality of care issues and training issues, looking at residency training requirements, and then this concept of structural competency. So we have cultural competency and structural competency. And then we'll go through the DSM-5 text revision, which the DSM-5 came out in 2013. The text revision came out in 2022, March. And there are sections of the DSM, which I'll be discussing. And in section 3, that's where we find our two tools, the outline and the CFI. And again, in the PDF that I can send you, if you send me your email, it has all of this material straight from the DSM-5 TR. So this is a one-sentence definition of cultural competence from the Joint Commission that accredits healthcare organizations. The ability of healthcare providers, individual clinicians, and healthcare organizations or systems of care to understand and respond effectively. Understanding is one thing, but responding effectively is another to the cultural and language needs. Language is explicit there because of its obvious impact on communication, brought by the patient to the healthcare encounter. So it's a way of meeting those needs. And so this is my elaboration of this. I see these are essential elements of the journey, that these are all different parts of the elephant, if you will, and that this is an ongoing journey. And it starts with understanding about yourself, your own cultural identity and values, prejudices and biases, and then the attitude and skills concerning cultural humility, knowing the limits of your assessment and treatment knowledge and skills, knowing that you don't know, and to ask, not assume. And that's easier said than done sometimes. But it's a very, very important skill to have. And the two tools actually provide you ways of asking questions. And then the attitude of valuing diversity, that it is important because it does impact on patient care. Um, despite laws that have passed in Texas or Florida that have outlawed, diversity activities at public institutions. Um, and then ensuring safety in concerning the power dynamics between the patient and the clinician. And then finally, how do we respond to the cultural diversity that we identify by adapting our assessment and treatment? And again, that's what our two tools will help us do. Now, just as background material, I'm going to go through this fairly quickly, is that over 20 years ago, there was this landmark report from the Institute of Medicine, now the National Academy of Medicine, that pointed out that our healthcare system needed improvement. And they talked about 6 quality outcomes as goals, and focus on 2 of them. One is patient-centered care, which I'm sure all of you have heard about. And this is aligned with culturally and linguistically competent care. As you can see, providing care that is respectful of and responsive to. That's really important. It's one thing to respect, to be sensitive, culturally sensitive, but then it's another to respond to what is being presented. And then the other outcome is health equity, equitable care that does not vary in quality because of cultural identity variables. Now, this is aligned with the concept of reducing or eliminating disparities in care. They're kind of 2 sides of the same coin. And the key word here is quality. It doesn't say providing care that does not vary because of cultural identity variables. In fact, if you ignore them, I would argue that you will not be providing quality care. Now, just turning very quickly to the training requirements in psychiatry residency training. Now, there are requirements in medical student education concerning these ideas of cultural competence. I won't be going over that, but just looking forward to those of you who would be planning psychiatry residency training, what is in the accreditation standards of the training programs. And in the early 2000s, the ACGME, which stands for the Accreditation Council for Graduate Medical Education, they accredit all training programs of graduate medical education across all specialties in the US. They set the standards for the training programs. And now, as I said, in the early 2000s, they started enunciating 6 core competencies that residents need to fulfill during their training. And this is broken down by specialties. So there's a psychiatry committee that decides on this. So for the psychiatry one, they, again, for the core competence of patient care, they have this background and intent statement, which in fact references that Institute of Medicine study that I mentioned earlier. And that a subcompetency there under patient care is that residents must demonstrate competence in evaluation and treatment of patients from different cultural backgrounds, diverse cultural backgrounds. Now, what might be related to that? Well, we have this subcompetency of forging a therapeutic alliance with such patients. And what might be related to that? Well, under the core competence of medical knowledge, we have listed here the cultural elements of the relationship between the resident and the patient. And this is very much aligned with the 4th part of the outline for cultural formulation that I'll be going over in just a moment. Now, this is a very, very important part of cultural competency, is to understand what these cultural elements are. And again, I will discuss this in just a moment. Um, and then there's a core competency of professionalism, and again, sensitivity and responsiveness to a diverse patient population, broadly defined. Broadly defined there. It's not just race and ethnicity, but as you can see, gender, age, religion, and so on, sexual orientation. And then finally, the core competency of systems-based practice is that residents in psychiatry must demonstrate an awareness and responsiveness to the larger context and system of healthcare, including the social determinants of health, as well as the ability to call effectively on other resources to provide optimal health care. So, concretely, an example of a social determinant of health is food insecurity. And so, knowing that, how are you going to provide for better food security for the patient after they leave the hospital? So, that's an example of what we're talking about here, that residents are asked to put this on their radar screen for things they need to learn about. So that aligns with very much this concept of structural competency. There's a great website that's simply structuralcompetency.org. It's one word, structuralcompetency.org. You may want to take that down. And there you'll learn more detail about it. But here is just a quotation from the two originators of this idea, Jonathan Metzl from Vanderbilt and Helena Hansen from UCLA. She's the interim chair there right now. That structural competency encourages clinicians to recognize how social, economic, and political conditions produce health inequalities in the first place. So it calls upon the clinician to understand about how these forces shape symptoms, diseases, and um, how to correct them in the physician-patient interaction, meaning when you have a patient with food insecurity, what are you going to do about it? And then beyond the clinic walls, which means what social actions might we want to advocate for to help deal with food insecurity, or housing insecurity is another example that our governor in California has really been emphasizing more recently, um, to deal with the housing insecurity. Now, turning to the DSM, I'm assuming all of you know what the DSM-5 is, the Diagnostic and Statistical Manual, 5th edition of the American Psychiatric Association, and it does provide narrative descriptions of the mental disorders and also the diagnostic criteria. But in addition to that, which is the bulk of the DSM, there is an introduction in section 1, and there's a section 3 of emerging measures, which is where we find our two tools. Now, in the introduction, what's in yellow here was added in the TR, which came out in March. That's text revision, meaning that the diagnostic criteria were essentially unchanged, but the narratives of the text of DSM, about 3/4 of it was revised. For example, instead of cultural issues, now the section is listed as cultural and social structural issues. So do you see how cultural competency and structural competency are now brought together here? That we need to be thinking about that. And what's underlined are the take-home points, if you will. So there's a very important concept here that's described, the cultural concepts of distress, with three subtypes: the cultural idiom of a distress, or like the presenting complaint, then the explanation or perceived cause, and then finally the syndrome, which is a clustering of idiom of distress and causes and other features. And these are defined here in the introduction. And in my PDF, I provide you all of this information from the DSM. Then there's a very important new section entitled Impact of Racism and Discrimination on Psychiatric Diagnosis, and how this was attended to, and gender differences has now been expanded to sex and gender differences. So in this new section, we find sentences like this that I think are very important to have stated in the text revision: that race is a social, not a biological construct. We speak about racialization as opposed to racial minorities. And so racialized identities are important because they are strongly associated with symptoms of discrimination, marginalization, and social exclusion. And then there are different levels of racism that's defined in a paragraph in this section. As you can see, in fact, the APA had a task force on structural racism throughout psychiatry, in the field of psychiatry and in the APA back in 2020, 2021, as an example of looking at the social, structural, and institutional levels of racism. And then finally, racism is an important social determinant of health. And this has been reiterated by the AMA and the American Public Health Association and other organizations. And then finally, clinicians should make active efforts to recognize and address all forms of racism, bias. I would include discrimination and stereotyping in clinical assessment, diagnosis, and treatment. So here are some of the other changes. As I said, racialized instead of racial, ethno-racial as opposed to ethnicity and race, Latinx, Caucasian is not used, and minority and non-white are also avoided. In fact, the term culture is now reworded to be like cultural context or cultural background, to help us understand the specificity of the cultural background of the person in front of us, as opposed to culture being some homogeneous block. Now, in the Section 2 is the bulk of the DSM. Here is where we find the narrative descriptions of the mental disorders and the diagnostic criteria. And in the narrative sections for some of the disorders, there is a culture-related diagnostic issues section and a sex and gender-related diagnostic issues sections. In the index of the DSM, you will find listings of where these appear. And then there is a group of conditions called the other conditions that may be a focus of clinical attention. These are the Z codes. They used to be called V codes, but now it's Z codes to align with ICD-10. So as I said, 3/4 of the text has been revised, including these sections that I mentioned here. And here in these sections, you'll find this kind of information: variations in symptom expression, also attributions or causes, prevalence data, cultural norms that may affect the level of perceived pathology, and attention to the risk of misdiagnosis. So an example here, if you go to schizophrenia, there's a discussion about what might appear to be psychopathological in one context may be seen as cultural in another. So like hearing God's voice, one would need to not immediately go down the psychopathology tract, but to evaluate what is the cultural context of the experience. So you would ask the patient, when do you hear God's voice? Oh, I hear it in church every Sunday. This has been going on for 30 years. Who else hears God's voice? Well, my family, the other people in the congregation. And has it been happening anywhere else? No, generally not. And then you may say, well, this sounds like it's very much consistent with the person's religious background. And you may conclude that, but that's not quite enough, because you always have to ask, has anything changed? So then the patient might say, well, now, over the last 2 weeks, I've been hearing God's voice every day, and it's getting louder and it's happening more frequently, and nobody else is around. And in fact, what's God's voice telling you to do or saying to you? And they're telling me to jump off the bridge. Okay. So there, the person may have a religious background where they're hearing God's voice in church, and that's part of their religious background. But in addition, they're now having this new phenomenon, which we might call an auditory hallucination, that is leading to a very negative outcome. So one has to be careful here, you see, not to reach a premature conclusion. That's where the ask, don't assume, comes in. Okay. Now, in terms of these Z codes, and I'm going to have to go through this quickly here because it can be a long story, but this is again, this is all in the PDF if you want it. Is the introduction to this section. These are conditions, environmental or psychosocial problems that may affect the diagnosis, course, prognosis, or treatment of an individual's mental disorder. These are now Z codes. And what's added in the TR is, why should we record them? Why should they be coded as part of the diagnosis? So you can have schizophrenia and you could have food insecurity as a Z code. If it plays a role in the initiation or exacerbation of a mental disorder, or if it constitutes a problem that should be part of the overall management plan. So again, a patient coming in, very psychotic and danger to self, you want to treat the schizophrenia if that's what your diagnosis is, or treat the psychosis. But if you find out that there's food insecurity, housing insecurity, these would be considered Z codes, and they also should be listed as part of the diagnosis so that you can address it as part of the treatment plan, that we would need to deal with this upon discharge, because otherwise the patient will likely return back to the hospital very quickly. Now, these are not mental disorders. That's why they tend to be forgotten. But hopefully this is changing now as people are recognizing more and more how important these are. So these are the categories of these Z codes, and under each category, there are specific codes. So you see their housing problems, and there's food insecurity. I'm not sure exactly where that is, but there are specific codes here. And I'm going to give you some examples in just a moment. Here are other categories. Now, this next slide is from Michael Compton and Ruth Shim, two psychiatrists that have written about the social determinants of mental health. Now, the 10 in yellow were ones that they wrote about in their co-edited book from 2015 with that title. And the 6 in white are new ones as of 2019. So in the lower left corner, for example, we have adverse early life experiences, or the ACEs, ACES. And then right next to it are discrimination, social exclusion, social isolation, which is associated with the racialized identities mentioned earlier in the introduction. And then above it, you can see things like homelessness and food insecurity, things that I mentioned earlier. Now, one of the new ones in the upper right corner is climate change. So so the big picture here is we have biomedical determinants of mental health, we have psychological determinants, and yes, we have social determinants of mental health. That's the big picture here. And if we focus on just the first two and neglect these, that is not optimal, care of the patient. Because, as you can see looking north, these social determinants have an adverse health and mental health outcome. And what below them, however, the public policies, the social norms, which impact on just or unjust distribution of opportunities, those are the upstream factors to the social determinants of mental health. So let me give you a very quick example. Back in 2021, a federal law was passed that increased the child tax credit at the federal level. And that public policy cut childhood poverty by 50%. So you see how that federal policy, that public policy, that upstream factor had a big impact on a social determinant of mental health. And then when that expired after a year, then childhood poverty went up again. So there are three books published by the American Psychiatric Press that actually provides a trilogy here, if you will. The original 2015 one that I mentioned, and then a 2021 on this concept of social injustice and mental health. And then this latest one about 7 stories of how federal legislation, such as the one I mentioned, impacted on social determinants of mental health. That wasn't one of them that they wrote about, but they talk about 7 other ones. And so under the abuse and neglect category, we have these examples, specific codes, and under relational problems, we see these specific ones. And then problems related to the social environment, we have social exclusion or rejection. So you see again how this is acknowledging that this could, again, initiate or exacerbate a mental disorder and how we need to deal with this in our treatment plan. And then also this one of acculturation difficulty, especially for like recent immigrants. And so a recent immigrant who has limited English proficiency and has poor income because they can't get a job and so on, then amongst many other issues that recent immigrants may be dealing with, that would be example here, and we need to address it, as part of the treatment plan. And then also there is this one of target of perceived adverse discrimination or persecution, broadly defined, as you can see. So again, the rise in anti-Semitism in our country, or AAPI hate. These are, that's been very well documented over the last few years. Certainly can be, if a patient comes in with complaining about that, this could be a category that acknowledges their distress. And then we have these examples, and we can only look at what's been happening in Ukraine or Gaza to, understand, to connect that this could certainly impact as a social determinant of mental health. And then we have religious or spiritual problem, which is a category that I helped get into the DSM-4 back in 1994, to acknowledge that patients who have a loss or questioning of faith, problems converting to a new faith, or questioning of other spiritual values, that these patients may not, that have these distressing experiences, may be, they're having a distressing experience, which may not be sign or symptom of psychopathology. So someone who has a mystical experience or a near-death experience, and they're very distressed about it because, it doesn't align with their sense of everyday reality. If they're distressed about it, well, if they come to see a mental health clinician or a doctor, hopefully they wouldn't be labeled as having a psychotic experience or, psychotic symptoms, but we would acknowledge that they might be having a religious or spiritual problem. So you can see how this is helpful for the differential diagnosis. Okay, now moving on to that third section, here's where we have our two tools and a section called the cultural concepts of distress, which further elaborates on that very important idea that is mentioned in the introduction. And now there are 10 examples up from 9. So the outline for cultural formulation first came out in DSM-4 in the 9th appendix. It was revised for the 5 and revised for the TR. The cultural formulation interview was new in the DSM-5 and is unchanged in the TR. Now, here is the outline for cultural formulation, the 5 parts. And so, when we say, well, what are the cultural issues in this case? Well, here is an outline to kind of help you formulate what the cultural issues are. So there are 4 fields of interrelated information that we ask the clinicians to gather. What's the cultural identity of the individual? The cultural concepts of distress, the cultural stressors and supports in the person's life, the cultural features of the relationship between the individual and the clinician. You see how that aligns with the accreditation standard that I mentioned earlier? Now, treatment team and institution was added in the TR to broaden that relationship question. And then the 5th part is the overall cultural assessment, meaning how do you summarize all this information that you have obtained, and how does that then impact on your differential diagnosis and your treatment planning? So getting back to, hearing God's voice, well, hopefully you will have asked those questions that I mentioned to further understand what that means, to help you understand, is this a cultural phenomenon related to the person's religious background, or is this an auditory hallucination, a psychotic symptom? And then another example I should have mentioned earlier is that misdiagnosis question of, and a typical example is the overdiagnosis of schizophrenia in African Americans that's been well documented, and how we need to guard against that overdiagnosis by understanding that. Now, in the DSM-5, for the DSM-5, there was a work group that I was part of that felt it would be important to provide ways of helping clinicians gather the information for the outline for cultural formulation. And so the cultural formulation interview was put together. It was field tested internationally. And there are now 16 questions, which I'm going to go over very quickly. I'm looking at the time here, and I see that it's ticking away. There's 16 questions, and then and the core CFI, and then the informant version just adds one more question. And then at the website listed on the left there are 12 supplementary modules of additional questions for deeper dives. So for example, in the core CFI, there are 3 questions on cultural identity. If you wanted to ask more questions, which you might have, then you would find the cultural identity supplementary module, and you'll have 28 additional questions. Again, all of this material is in the PDF. If you want it, I can just send it to you, and it has all of these supplementary modules. Now, the last four on the right column there are around specific patient populations. So if you're working with children and adolescents or older adults or patients where religion or spirituality comes in, or immigrants and refugees, then there are these specific supplementary modules for those patients. So this is what it looks like in the DSM. It's not just a list of 16 questions, but there's a guide to the interviewer and actual wording that you can use. And the first question, as you can see, is what brings you here today? So now I'm going to go over the 16 questions and relate them as quickly as I can to the outline for cultural formulation, because they're not in the same order. You see, we thought what brings you here today would be the natural place to start, rather than what is most important about your background or cultural identity. So wherever you see problem in caps and brackets, we'd like you to use the patient's words. So what brings you here today? Wind illness. Well, sometimes people have ways of describing their problem to their social network. How would you describe your wind illness to them? And what troubles you most about your wind illness? And then the next two questions are about cause. Why do you think this is happening to you? And what do you think are causes of your wind illness? And what do others in your social network say are the causes of your wind illness? So this relates to the cultural concepts of distress. This is the actual language in the TR. Again, what's in yellow is added. What's underlines the take-home points. All of this will be in the PDF. As you can see, the three subtypes that were defined in the introduction are listed, and we want to know the level of severity and meaning of these distressing experiences in relation to the individual's cultural background. So that's why we ask about the social network. And then the last sentence here is the assessment of coping and help-seeking patterns should consider professional as well as traditional, alternative, or complementary sources of care. So here we're interested not only in the visits to the doctor, but also the use of Tai Chi or acupuncture or herbal medicine or spiritual healers. And then, as I mentioned, there is this section on the cultural concepts of distress, where this was further described, and hikikomori as an example was added. We now have 10 examples, and in this section, there's a little description of each of these 10 concepts as just examples. So in the far left column, we have the actual name. And then in the middle, which of the three subtypes, and then in the far right, where in the world these were originally described. And of course, patients from all over the world come to the US now. And some of these are related. So nervios in the middle there is an idiom of distress, but it is also part of the ataque de nervios, the cultural syndrome. So this is the cautionary tale that I highly recommend if you haven't looked at it already. This is based on a true life story of Hmong, a Hmong infant. Hmong is a ethnic group from Laos. A Hmong infant who was diagnosed by a neurologist and a pediatrician in the Central Valley of California as having a seizure disorder. And they had a biomedical explanation and a biomedical treatment, namely medication. However, the family called it the spirit catches you and you fall down. And they had a supernatural cause for it. And their treatment method was the use of shamans. Unfortunately, there was never a appreciation of this difference or a negotiation. And this led to the family not complying with the medication because they didn't quite understand how that connected to, their understanding of the problem. And this led to the infant having a prolonged grand mal seizure and was left in a vegetative state for 10 years before dying. And so this is a cautionary tale for us. Now, the next two questions are about supports and stresses. Are there any kinds of support that make your wind illness better? And are there any kinds of stresses that make your wind illness worse? So this relates to part C. The first sentence has it all really. What are the key stressors and supports in the social environment, both local and distant events? And then this next sentence was added, a very important sentence, which says that the social determinants of mental health should be listed here. So this is those Z codes that I mentioned earlier are examples of these social determinants of mental health. And this is a very important sentence because it brings together cultural and structural competency. Do you see what I'm saying? Is that in the outline for cultural formulation, we have this sentence, which means it's very important to understand about the social determinants of mental health as part of the cultural formulation. And then the next sentence gives you specific domains to be thinking about. Religion and family, go back to DSM-4. Social networks was added in DSM-5. And these domains could either cause stress or provide support, and we would need to understand that. So just to elaborate on this a little bit, when they say local or distant events, well, example of local would be the interpersonal relationships across those three domains. But we also need to look at the Z codes and the social determinants of mental health, local by geography or time, and distant by geography or time. So take anti-Semitism, well, that's been rising in our country recently and attacks in various cities and so on. And so that's local by geography and time. But anti-Semitism has been a worldwide or nearly worldwide phenomenon going back centuries. And then climate change, that's happening like here and now with storms and hurricanes and wildfires and rising temperatures. That's local, it's happening right now, but it's also distant because it affects the whole earth. And this goes back to the beginning of the Industrial Revolution. So again, whenever religion or spirituality comes up, go back to that supplementary module. Family is a very big topic, and we need to enlarge our thinking about this to think about extended families and how family characteristics, we need to think about the cultural identity variables in these families. And then what are supports or strengths? So Pamela Hayes has a book in which she talks about what some of these might be that enlarges our radar screen. So it might be very important for a particular patient, like their religious faith or spirituality might be very important for that patient, or extended families might be very important here, or involvement in a political or social action group might be very important for this patient. And then things here like caring for animals. This basically enlarges our radar screen. And so here are some of the books here. The Pamela Hayes book is a very helpful one, and also the Ethnicity and Family Therapy, where there are 52 chapters, not only on Vietnamese families and Japanese families, but Irish families and Italian families. So the next three questions deal with cultural identity. For you, what are the most important aspects of your background or identity? Are there any aspects of your background identity that make a difference to your problem or your wind illness? And then are there any other aspects of your background or identity that causing other concerns? It's like a second pass question. So this relates to part A, the cultural identity. This is what we saw in the 4. You can see race, ethnicity, immigrants, biculturality, and language are specifically mentioned. Added in the 5 was this sentence that explicitly increase the number of cultural identity variables to think about. And then in the TR, this is even further enlarged. There are more specifics. And then a very important sentence, note which aspects of identity are prioritized by the individual and how they interact or intersectionality. So again, we will never understand a person's cultural identity simply by looking at them. We have to ask, what is most important about your background or identity? And then we need to understand how these cultural identity variables intersect as opposed to just focusing on race or just focusing on gender. And then, then this is the continuation of it. This is pretty much the same as we've seen before. Now, let me give you two ways of visualizing that intersectionality. So Pamela Hayes, in her book, Addressing Cultural Complexities in Practice, uses the word addressing as an acronym to indicate different cultural identity variables that you can see there. But this is not a complete list because language is a very important cultural identity variable, but there's no L in addressing. That's why it's over there on the right in brackets. And then here's another example from a great website. Where at 8 o'clock we have linguistic characteristics going clockwise to spirituality at 5 o'clock. You see the different cultural identity variables. We're interested in how they intersect. And in this diagram, we have at 6 o'clock health, beliefs, and practices. That's part B of the outline, and the environment, that's part C of the outline. And this is what we need to think about. So again, ask, don't assume is really, what we need to ask. And cultural identity is related to all of the other aspects of the outline for cultural formulation. And I'm going to skip over this. So the next few questions are on self-coping and past help seeking and barriers to care. And then a key question, number 14, is what kinds of help do you think would be most useful to you at this time for your wind illness? That's a very, very important question to ask. And then what about your social network? And this relates to that, going back to part B, the cultural concepts of distress that we mentioned, and people can have all different kinds of care. Now, the last question here is very, very important. It just touches on the clinician-patient relationship. Sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this? And is there anything we can do to provide you with the care that you need? This is one of the most important questions to ask. And this relates to part D, the cultural features of the relationship. And the first sentence again says it all. Identify the differences in the cultural identity between the clinician and the patient that may cause difficulties in communication and may influence diagnosis and treatment. And very important, experiences of racism and discrimination in the larger society may impede establishing trust and safety. And this can impact on the process of getting a history, understanding what's cultural, what's psychopathological, and also the therapeutic alliance can be impacted here. So how do you operationalize this? I know I have 6 minutes left. One is to understand, the clinician needs to understand their own cultural identity. That's absolutely critical. And then you need to compare the cultural identity of the patient and that of the clinician. You can draw a little table where you have in the left-hand column the different cultural identity variables like age and gender and race, ethnicity. In the center, you put the patient's variables, and in the far right, you put the clinician's variables, and you look at the similarities and differences. So, for example, if the patient speaks Cantonese only and the clinician speaks English only, there's a difference in language. And that's going to cause a communication problem. So I need to understand that. I need to respond to it by getting a trained interpreter or working through a clinician that speaks Cantonese or referring the patient to a Cantonese speaking psychiatrist. Second example would be I'm a man and a woman comes in and seems reluctant to give me any information. And at the end of the interview says, well, I'd like to speak to a woman psychiatrist. So do I go down the psychopathology tract? I say, patient hasn't given me much information. She must be treatment resistant. She must be passive aggressive, all of this. Or do I ask and not assume, can you tell me more? And she says that, well, I had a hard time with my husband. I don't want to get into it. We later find out that she has a sexual abuse history and she has difficulty trusting men. So there, a cultural identity match with a woman psychiatrist might make a big difference in terms of forming a therapeutic alliance and doing psychotherapy and so on and so forth. And then the last example here is that I'm an atheist, and I asked the patient, what brings you here today? And the patient says, well, I've lost my faith in God and God is punishing me for my sins. So here we have a difference in religious orientation, and I need to be aware of the differences here, and so I don't inadvertently, uh, you know, psychopathologize the patient's beliefs in God and religion. Right. And then we need to look at how these similarities and differences can affect communication and all these things that I mentioned here, all the aspects of a therapeutic alliance. And of course, we need to think about bias that could happen either explicitly or implicitly across different uh, cultural identity variables. This could go for the clinician bias towards the patient or the patient bias against the clinician. And then finally, what would help the clinician to provide optimal care? That's the bottom line question. Sometimes cultural identity matches, like in the first two examples I gave, would be very important. Other ways to increase your knowledge and skills in this area, getting a cultural consultation from a faculty member or trainee or community leader might be very helpful. PubMed searches, books, and so on. And finally, the last part here is, as I said, how do you summarize this? How does this impact on your differential diagnosis and your treatment plan? And so, yeah, misdiagnosis can lead to mistreatment for all of the reasons we mentioned earlier. And so how do you operationalize that? Well, go back to use our two tools that I've gone over with you here today and go back to the culture-related and sex-gender-related diagnostic issues sections, and also review and add the Z codes so that we can address the social determinants of mental health. Finally, in terms of treatment planning, all of this that I've discussed here can help you with the process of treatment planning. That is, how do you negotiate and manage a treatment plan to maximize adherence and compliance? I mean, a question you ask every day with every patient perhaps is, are you taking your medication? Well, are there cultural issues here that might impact on the patient's response? And then at the content level, and I think I'm going to stop here so we have a few more minutes for conversation. Yeah. There are books here listed that you can access. There's an excellent online training module that you can access. And also there's a Society for the Study of Psychiatry and Culture. You can look it up at psychiatryandculture.org. We're going to have our annual meeting in Toronto in April. There's a journal and so on, structuralcompetency.org. So I'll stop now, and any questions that people might have. You can type them in the chat or just ask them quickly.
I was wondering if you could just add your email again.
Yeah,
Um,
yeah. Yeah, just email me saying you want my PDF and I'll be happy to send it to you. Has all the slides, has all the backup material, articles, and very easy for me to send it to you. I'll also send you my DEI resource guide that you can get at adamsef.org. It's a 50-page DEIA resource guide. I can also send that to you as well. I know this is overwhelming. It's a lot of material. I hope that it was a useful introduction showing how cultural issues has certainly come into psychiatry in a very real and meaningful way. And it's much different when I trained in psychiatry back in the 70s when culture was not even on the radar screen. It wasn't even discussed.
Well, thank you so much, Dr. Liu, for giving us this presentation. I really learned a lot, and just barely even having started third year, it is already super relevant. So I really appreciate it, and thank you so much, everyone, for coming. This will also be, or it has also been recorded, so it'll be on the YouTube. Yeah, and again, any of the PsychSign members, if you ever have any questions, feel free to email me. And thanks, everybody.